Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about vitiligo, but from a patient's journey perspective. Our moderator this evening is Dr. Naiem Issa. Dr. Issa is dermatologist and dermatologic surgeon, Forefront Dermatology in Vienna, Virginia. We have as presenter this evening, Dr. Firas Hougeir, who is Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and President of the Southeast Dermatology Specialists. We'd like to thank our supporter, Insight Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane, and the dial-in information will be displayed. If you're having technical issues, or if you'd like to submit a question to our faculty, please submit your question using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. A certificate will also be issued upon completion of the evaluation survey. Credits must be claimed by April 7th. Again, if you want to submit questions to our faculty, please submit your questions using the question chat pane on the right-hand side of your screen. And I wrote a little note there so that you can see where to type in your questions. So this activity is a CME activity, and it has been designed to meet the educational needs of dermatology healthcare professionals involved in the care of patients with vitiligo. There's a knowledge gap among healthcare providers on how to treat vitiligo within their patient populations. In support of improving patient care, this activity has been planned and implemented by Medical Education Resources, MER, and International Dermatology Education Foundation. MER is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. The disclosure of conflicts of interest are displayed here for our speakers, as well as for International Dermatology Education Foundation and MER. The contents and views presented in this educational activity are those of the authors and do not necessarily reflect those of Medical Education Resources, International Dermatology Education Foundation, and Insight Dermatology. The authors have disclosed if there is any discussion of published and/or investigational use of agents that are not indicated by the FDA in their presentation. Before prescribing any medicine, primary references and full prescribing information should be consulted. Any procedures, medications, or other courses of diagnosis or treatment discussed or suggested in this activity should not be used by clinicians without evaluation of their patient's condition and possible contraindications on dangers in use, review of any applicable manufacturer's product information, and comparison with recommendations of other authorities. The information presented in this activity is not meant to serve as guideline for patient management. A certificate will be issued upon completion of the evaluation survey, and again, credits must be claimed by April 7th. The link will be emailed to you within 1 to 2 days of the webinar, and if you have any questions about this activity, please contact MER at the number displayed or jsykes@cmepartner.org. So without further ado, I am going to pass the floor virtually to Dr. Naiem Issa.
Thank you, Roxanne. Good evening, everybody. Thank you for being here with us. My name is Dr. Naiem Issa. I'm located in Vienna, Virginia. I practice with Forefront Dermatology, and I am a dermatologist and dermatologic surgeon by training, and perform a lot of medical dermatology services. And tonight, we would like to bring to you this program on vitiligo by the International Dermatology Education Foundation. As you know, is headed by the president, Dr. Leon Kursuk. And IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. And tonight, we have a very pleasant treat and would love to introduce you all. But first, we would like just to briefly discuss that the IDEF has had numerous programs in the past regarding different medical dermatology conditions, and brought to you by different key opinion leaders that you all know very well, and span a variety of medical issues, and more to come in the future series. And for this evening, we have the great pleasure of introducing Dr. Firas Hougeir. And Dr. Firas is over in the Department of Internal Medicine, as well as practicing dermatologist over at the Philadelphia College of Osteopathic Medicine. And he currently practices in Southeast Dermatology with Southeast Dermatology Specialists, and is president there. With Dr. Firas, if you would take the stage.
Thank you, Naiem, very much for introducing me, for having me. It really is a pleasure to talk about our subject today, which is really the patient journey in the treatment of vitiligo over the several years that we've had in the past, and some of the new treatments that we have today for vitiligo. Before we move forward with the presentation itself, we're going to have a couple of quick poll questions, and please go ahead and answer them, and there will be a percentage of answer we'd look at, and we will see during the presentation what the answer of that would be. So the first question is this one. On histologic evaluation of vitiligo lesions, we can find one is melanocytes but not melanosomes, melanosomes but not melanocytes. Number 3 option is melanosomes and melanocytes. Number 4 option is neither melanocytes nor melanosomes. So I'll give you guys some time to vote on this. Okay. And actually this was quite evenly split, about a quarter melanocytes but not melanosomes, a quarter melanosomes, which are produced by melanocytes and sometimes, and also can be transferred to keratinocytes, for example, but not melanocytes. 17% says that we can have both melanosomes and melanocytes, and 33%, the majority, saying neither melanocytes nor melanosomes. We won't give the answer right now. We will see it through the presentation. Okay. Now, polling question number 2. Which drug is, not if, is FDA approved for the repigmentation of vitiligo lesions? Option number 1, tofacitinib, which is a JAK inhibitor. Option number 2, tacrolimus, which is a calcineurin inhibitor. Option number 3, ruxolitinib, which is also a JAK inhibitor. Option number 4, A, which is tofacitinib, and C, ruxolitinib. And option number 5, all the above. Give you some time to vote. And the answer is 6% tofacitinib, tacrolimus 3%, ruxolitinib 43%, a good chunk 30% A and C, and all the above as drugs which are approved for by FDA approved for the repigmentation of vitiligo lesions as 18%. And again, we'll talk about these as we go forward. Okay, so as disclosure, I am consultant. I'm a consultant, a speaker, a researcher, have been or will be for any and all of these companies. I'll leave you a little bit of time to read them. Okay, so let's start with vitiligo. We're here to talk about that. What is vitiligo? Clinically, it's a depigmented, well-demarcated patch, usually enlarged centrifugally, meaning from center and out. The lesions often start on the extremities and the face of patients, especially periocular and perioral. And we have multiple variants of them, right? We have segmental, non-segmental as a big split, but you also have trichrome. You can have multiple 3 colors, especially at the edges, as the pigment disappears, quadrichrome as well. Vitiligo is one of those disease states that kebnerizes, like psoriasis, like lichen planus. Kebnerization is part of vitiligo, and we should be aware of that because that plays a role in some of the treatment modalities, treatment options our patients have, whether they're still kebnerizing or there's evidence of kebnerization. before we treat them or not, especially when it comes to, we'll see later, the surgical treatments. And these are some of, some drawings of what vitiligo could look like. Focal, segmental follows Blaschko's lines a lot, and acrofacial is again what we were talking about before. Vitiligo vulgaris is what we, from the name you can tell from your average run-of-the-mill vitiligo, and you can have vitiligo universalis and vitiligo where kind of like alopecia universalis, where you have quite a bit of depigmentation due to vitiligo in these patients. So the treatment for these patients is different than treatment for your average vitiligo patient. On pathology, there is complete destruction of melanocytes versus other pigmentary disorders where you can have a destruction or decrease or inflammation of melanocytes or decrease of activity of melanocytes. In vitiligo, there's complete destruction of melanocytes. You can find some inflammation at the edge of the lesion, usually lymphocytic, and that could translate clinically with the red border of vitiligo. But because of destruction of melanocytes, there's therefore no melanocytes and no melanosomes. And if you do a Fontana-Masson stain, you will not find positivity. There'll be no melanin. Melan-A and S100 stains are also negative because there's no melanocyte. There are no melanocytes unless you get some keratinocytes in there as well. The picture I'm showing here, you can see a positive Fontana-Masson stain. This is desmoplastic melanoma. This is not what you would expect in vitiligo. There would be no color in a vitiligo lesion staining, immunochemistry in this one. So again, when it comes to vitiligo on pathology, what makes it different from hypopigmentation is that your pathologist will not find any evidence of melanocytes or melanosomes. And looking at epidemiology, it's about 1 to 2% global prevalence, about 1% in the United States. Female prevalence is equal to male, although in the past we used to think that there was more female prevalence, but the thought is that there was more females coming forward with vitiligo and an easier or earlier diagnosis of it because of makeup and such. No racial differences have been seen so far with vitiligo across studies. And when it starts, it usually starts around 20 years old, and can happen also as pediatrics early on and continue to progress. We can also have it as adults around usually 20 years in the 20s and such. Now you can have comorbidities with vitiligo that we have to be aware of. Several syndromes include uveitis. You can have ocular abnormalities. Remember, melanin is important in the eyes. Autoimmune disease, especially in pediatric vitiligo. When I have a new diagnosis of vitiligo, especially in younger patients, we absolutely check for TSH and for thyroid antibodies. There's a high correlation of thyroid disease and vitiligo, especially early on. Remember that somebody with vitiligo can also have auditory issues. Melanin is important in the auditory canal and in the auditory system. So remember that as well. Now, if we have a patient that shows up as an adult with a sudden onset of vitiligo, sudden onset of leukoderma, we have to think about melanoma. The way this would work, the reason this would happen is that when you have melanoma, your body tries to fight it. So the T-cell reaction to the cancerous cells of the melanoma can also go after melanocytes that are not around the melanoma throughout the body. There's actually a belief and some studies that show that people who have melanoma-associated leukoderma have a better survival rate and better prognosis than people who don't, because the immune system is already reacting and going after the melanoma rather strongly. Some of the checkpoint therapies as well for melanoma can cause melanoma-associated leukoderma as well. So, as a pearl, if you have a new onset vitiligo, and especially an obvious new onset vitiligo, multiple lesions in a patient who's an adult, look for melanoma. Try to make sure there's no melanoma and no melanocytic lesions that look a little bit odd in this patient. So how do we treat vitiligo? It can be as easy as just sun protection, right? In light-skinned patient, Fitzpatrick 1, if they don't tan, you can barely see the vitiligo, and if that is bothering them too much and no comorbidities can be seen, that could be all you need. I have a patient who's very pale, who happened to go to South America and went hiking for about a month in South America. She came back and her vitiligo was very, very obvious. We knew it was there before, but it really was not an issue. When she came back, it became much more obvious. So remember that. So skin protection is extremely important. It's the basics of vitiligo treatment, because vitiligo does not tan. Everything around it does tan. Topical therapies, including JAK inhibitors, including calcineurin inhibitors, topical steroids, and vitamin E analogs. We'll talk about that in a bit. Systemic therapy includes corticosteroids. Also, JAK inhibitors are being studied. Afamelanotide was also being studied, and some supplements that we'll talk about that have had some good data over the past several years. Light and laser therapy is also used for the treatment of vitiligo. Surgery, which we'll talk about, also is used. It is more commonly used, I think, in the Sub-Saharan continent, where vitiligo affects patients tremendously and much more severely, and they're willing to go to do much more aggressive treatments for it. But they're very interesting, and we do them as well in the United States, but not as commonly. And finally, depigmentation. You know, when you have a patient who has vitiligo universalis, as we talked about, we saw earlier, sometimes the question becomes, we try to bring the pigment back or take the rest of the pigment away. And of course, we all think of Michael Jackson when we think of that. So let's start with the topical treatments. Steroids. Now, steroids is something we all use for vitiligo. We've used it for many years. They're best for localized areas. You know, we don't want, and we, you know, there are potential systemic absorption and issues with using steroids on very, very large areas of the bodies, especially in kids. Long-term treatment risk of atrophy should also be considered. Remember, vitiligo is not a disease process that reverses very fast. We're talking long-term treatment. So when you're looking at these long-term treatments, be aware and make sure your patient is aware of some of the sequelae of using long-term steroids to a specific area. Calcineurin inhibitors, tacrolimus, pimecrolimus, don't have these as an issue, and they can be used on longer term. Of course, they have the black box. You have to explain that to the patients as well. But we use them a lot in combination. And one of the things that we do is use calcineurin inhibitors, pimecrolimus, for example, or tacrolimus during the week, and use a high potency steroid during the weekend on these lesions. They've also shown good evidence and good improvement in combination with light therapy versus light therapy alone, or let's say tacrolimus alone. So using them in combination with light therapy has been helpful for our patients. Vitamin D analogs act on the T cell. They inhibit pro-inflammatory cytokines that play a role in vitiligo, and they also upregulate melanogenesis. So the use of them as a monotherapy and also in combination, whether with other topicals as well as light therapy, has been proven to be helpful, and that is an option that we can recommend for our patients. So the next topical treatment, ruxolitinib, I'm going to spend a little bit more time on. And the reason I'm going to spend a little bit more time on, because it was approved recently as the only FDA-approved drug for the treatment of vitiligo with the goal of repigmentation of vitiligo. There's another drug that is approved for the depigmentation of the remaining lesions of vitiligo, but this is the only approved drug for repigmentation of vitiligo. And we're going to talk about the phase 3 trials. We're going to talk about what we see and why this was approved for vitiligo. Again, it's Janus kinase inhibitor. The True V studies were the studies that were the pivotal trials that got it approved. These were in patients that were 12 years or above. They were in patients that were that had a BSA of vitiligo of more than 0.5% on the face. So it was separate between the face and the body. FAAD evaluated the face, which is the vitiligo scoring instrument of the face, and then you also looked at the TVASI, which is the body, and had to be more than 3% as well. The total body surface area had to be less than 10%. People who were who had leukotrichia, meaning no melanocyte or pigment of the hair within the face lesions were excluded. People who had other dermatologic disease that could make the assessment hard were excluded. People who had used previous JAK therapies were also excluded. And you could not use other vitiligo therapies before at baseline. You had to have a washout period. And they looked at ruxolitinib BID, 1.5% versus vehicle. And that was all the way to 24 weeks, a double-blinded study, and an extension trial for 28 more weeks after that. And everybody went then on the active treatment. The primary endpoint were the patients who achieved FVASI 75, so 95% improvement of VASI at week 24. They looked at secondary endpoint, which is the FVASI, so face VASI 50 and face VASI 90 at week 24. They looked at the total VASI 50 at week 24 as well. And they looked at the VNS, and VNS is a measure of noticeability of vitiligo. They asked, they looked at whether these patients had a lot less noticeable vitiligo or no longer noticeable vitiligo at week 24. And of course, they had safety and tolerability, and we will see that in this deck. The demographics of these patients, you had more female than male in one of the active arm, but mostly actually pretty even. 81% white, and the crushing majority of the patients were Fitzpatrick skin 2 to Fitzpatrick skin 4. So few 1 and also few 5 and 6. So the darker, very darker skin or darker skin at Fitzpatrick 5 and 6 were not very well represented. I wish it was, but you had about 80 to 85%, up to 90% actually were between Fitzpatrick 2 and 4 across the study. And when you look at the facial body surface area and the total body surface area of the body, we're looking at 1% for the face, about across all groups, and about 7%. You remember you had to have more than 3%, but you had an average of 7% for the body as well. 36 or 32%, 31%, 41, and 37. So between 31 and 41% of the patient had vitiligo in childhood. 3/4 of these patients had stable vitiligo, which is very important to know, versus 25% had progressive vitiligo. And it's important to know when you're treating these patients, by the way, are they stable or are they progressive? Is vitiligo very active, which is kind of sitting there? Because that gives you different options as well. So remember what we said, that you had a higher likelihood of having thyroid disease when you had pediatric vitiligo, and given that 30% had it in their childhood years, it wouldn't be too surprising to know that quite a few of the patients had thyroid disorders, but between 13 actually 22%. You had one case of diabetes mellitus. You had one case of pernicious anemia. So vitiligo, again, as an autoimmune condition, can play a role and could be an indicator of potentially other issues going on. Previous therapy-wise, 32%, so 28 to 32% had topical calcineurin inhibitors, 24 to 30% had topical corticosteroids, and then about 27 to 40% had previous phototherapy. That is the patients that we see in the study, which is really what we see in our clinic. When we see these patients to our clinic for vitiligo, they've tried calcineurin inhibitors. Usually at this stage, they should have at least. Topical steroids has been tried as well. Phototherapy, if it was available and feasible for them, was usually tried as well. So what did we find? In TRuE-V1 and TRuE-V2, by week 24, 29.8% had the FVASI 75 response, were responders, versus 7.4% in the placebo group. If you look at the extension, I'm going to look at TRuE-V1 only because both studies were very similar. So 22% difference at week 24. But in the extension, with time and more time, by week 40, you have now 45% in in the group that was ruxolitinib all the way through, and even the group who went from placebo to ruxolitinib started increasing at 15%. At week 52, 52%, over 50%, 52.6% achieved FAAD 75. And when you look at the group that was initially ruxolitinib, or sorry, initially placebo or vehicle, and then ruxolitinib, even that group by week 52 is now at 26%. And the data was very similar in the second trial, TRuE-V2. Looking at FAAD 50, so 50% improvement. You're looking at, and that, we always look at trial responders and clinical responders, right? And a 50% improvement in these patients these are happy patients. These are patients who are having hope by the vitiligo improving. So FAAD 50, even at week 24, you already have 51%. By week 12, you have 26%. And by week 52, we've reached 75% that have achieved FAAD 50, right? So with time, they're continuing to improve with ruxolitinib. Looking at FAAD 90, 90% improvement, 15% at week 24, 29% at week 40, and 32% at week 52 in the TRuE-V1. The TRuE-V2 is 16, 25, and 27. So we see that we have a good subset of the patient who respond very well and relatively quickly. Within 24 weeks, 15% having an FAAD 50. So it has shown good efficacy, including with pretty stringent criteria with the FAAD 90 to be achieved there. So we're having good hope and good results with these patients. When we treat them in the clinic, the first thing I say, listen, you gotta give it time. This doesn't work very well or very fast. Remember, 24 weeks, we talk in weeks, that's 6 months. So give it time, give them hope, but they will see improvement and they will see changes, which will make them happy. Looking at body vitiligo, similar findings with 20% at FAAD 50 at 24 and 53% at week 52. So when I say similar, meaning improvement, but not to the same extent at the face. And TRuE-V2, same thing, have very similar findings as well. 75 now, all the way to 20% have a FAAD 75 at week 52. Now, when you look at week 24, the FAAD 75 numbers aren't as impressive. They are bigger, but aren't as impressive. 4.1% versus 1.8% in TRuE-V1, and 8% versus 1.8% TRuE-V2. So really, when we're looking at the body, things take a little bit longer to get better in the body. And the noticeability factor measure, how noticeable is it? And at week, so 4 and 5, right? So barely, not very noticeable or not noticeable at all. 24% at week 24 and 39.9% at week 52. And same thing with TRuE-V2, 20% and 32% at week 52, week 24 and week 52. So these patients do well. It is changing them. It is changing their life. And BSA response, again, the improvement of mean FBSA percentage change, we're talking about -44% and -41%, depending which study you're looking at, by week 52. So efficacy has been proven and has done well with this drug, which is again a topical treatment. Now let's talk about adverse events. Application site acne. Application site acne happens. You have 6 times placebo, 6% versus 1%. Pruritus, 5% versus 3%. Nasopharyngitis and headaches, 4% versus 2%, 4% versus 3%. UTIs, again, we're looking at studies that lasted 24 weeks and then 52 weeks, but UTIs, 2%, application site erythema, 2% versus less than 1%, and pyrexia of 1%. So looking at all these, no major adverse events that things to speak of. Acne is an adverse event that happens in the whole group. We are, as I said, we are dermatologists. We know how to treat acne, and the way I deal with this acne is the same way I would deal with any acne if it were to happen. Now looking all the way to week 52, 1.2% serious infections versus 0 and 0.8 versus 0 that we could see. Viral infections, herpes zoster is something to be aware of that could happen in this whole family, but we're talking about 0.4. We're talking about 0.4 per 100 patient years. It's not a percentage, sorry. 0.400 patient years, very, very, very small, zero in placebo. So be aware of it, talk to your patients about it, but not something to be extremely worried about. Well, how about malignancies and such? Remember, this is a Janus kinase inhibitor. It is a topical Janus kinase inhibitor, right? So we're looking at all these, but we're talking about very, small numbers. 0 for lymphoma, 0.4 per 100 patient years for prostate cancer, 0.4 for basal cell carcinoma per 100 patient years, and 2.2 for squamous cell carcinoma in the vehicle, by the way, not in the ruxolitinib. So we're, remember, you have to have there's a background in the general population as well. What we're picking up here is not 100% sure. I do discuss this with patients. I'm not worried about it. I would give it to my kids if I need to. And these are some pictures of anti-ruxolitinib studies. This was published in 2015 at the American Academy of the JAD. And this was week 4, by the way. This is a patient who, and how they did it by week 4. You can see the improvement already in the smaller areas here, and they're not as much here. The picture lower actually delineate the vitiligo areas. You could see them at week 8, the improvement at week 8, and how this broke down. Like, you have actually repigmentation in this area completely, and this is then at week 20. So improvement that could be clinically noticed easily in these cases. And this here is a treatment that and results that were published at week 24 and 52 in the Lancet in 2020. And you can see here, I think you can see my arrow, but you can see the difference. This is baseline of FASI 150, 1.5%, and by week 24, this lady has an SVASI of 0.13, and by week 52, the improvement is dramatic, right? So we have good results with this drug, and we've seen this in our clinic as well. All right. So this sums up the topical treatments of vitiligo that are available to us. That are known. Again, the only FDA treatment which is discussed ruxolitinib, FDA-approved treatment is ruxolitinib for repigmentation of vitiligo. Now let's talk about systemic treatment. Systemic JAK inhibitors are being studied. They are not approved yet. They're being studied for vitiligo. Now, how do they work? Interferon gamma activate, and we believe interferon gamma activate the JAK-STAT pathway, and then you have chemokine 9 and 10 get activated and produced, by keratinocytes because of that, and they recruit CD8 plus T cells, right? So they recruit active T cells that then get involved in melanocyte destruction and also promote the production of more interferon gamma. So you get this vicious cycle where you then have more and more destructions of melanocytes. And therefore, if you're able to inhibit this pathway, then it should potentially help. And a few studies are actually happening with this and have been done with this. This is a study from Bangladesh. Again, a lot of the studies and a lot of the work on vitiligo, although we're very good here in the United States, but Southeast Asia has been working hard on vitiligo for many, many years. And you'll see a lot of the studies and a lot of the surgical methods all come from there. So this is a study that was done, that's being done actually now. They're recruiting now for tofacitinib as a monotherapy for vitiligo patients. A few articles and a few studies were done that showed the effectiveness and safety of tofacitinib with combination in UVB, which, by the way, took over. PUVA is also one of the things that has been used and is used for vitiligo, but narrowband UVB and extramural laser have really taken over when it comes to that. So JAK inhibitors as a whole, we know can help. This is why the topical JAK inhibitor was studied and was approved by the FDA for it. Afamelanotide is an analog of alpha melanocyte stimulating hormones, and it has been studied and is being studied for the treatment of vitiligo because it stimulates melanocyte proliferation. And studies were done with afamelanotide and narrowband UVB phototherapy, which showed really good results. So if you see here, the top picture is in the forearm. This is a combination of afamelanotide and narrowband UVB. You see the results that we got here at day 68. The bottom picture is narrowband UVB alone, these day 0 and day 59. There's improvement, but the improvement in the above picture is quite impressive. So there are quite a few studies and studies are being done with this, as we speak. And there are now studies with the first enrollment in 2022 of vitiligo patients being treated with afamelanotide as a monotherapy as well. And this was done in patients with darker skin. So we don't have the results of that yet, obviously, but there's a lot of hope and a lot of future treatment that can be hopefully counted on for the treatment of vitiligo. Polypodium leucomotus is an extract from a fern, a South American fern. This is an article which I was one of the authors of in 2014, and it is an over-the-counter extract. It's multiple brands sell it, multiple pharmaceutical companies and nutraceutical companies sell it, and many studies were done, in fact, with this. And the article that I showed you, we reviewed the literature, what was available, and these were anywhere from randomized prospective studies and placebo-controlled studies. Actually, all of these were pretty high level articles and studies, and it showed that Polypodium leucomotus with narrowband UVB seemed to have better results than narrowband UVB alone. Polypodium leucomotus with PUVA had better results than PUVA, and that's another one as well. There's again different doses that shows the addition of Polypodium leucomotus has had beneficial effects in the treatment of vitiligo and other pigmentary disorders as well, but vitiligo is what we're talking about here. So it is something that I consider giving to my patient. It is something that I recommend. I do not, you can actually, some of the brands can be sold in the office. I do not sell it in the office. But they're really readily available at pharmacies and other venues as well. Okay, so now let's talk about light therapy. I won't talk too much about it. Narrowband UVB has been used for vitiligo. It is tough. We can't in the private setting and for these patients to come in multiple times, because really the treatments can last weeks and weeks and weeks. It's tough for them to get, but it is something that helps. Largely replaced PUVA. I don't know of many places that still do PUVA, that not academia. The excimer laser at 308 nanometers works well. Again, difficult, expensive, very rarely covered by insurance, but it's something that is an option for our patients. And we can, of course, and we should, if we do light therapy, combine it with multiple treatments and multiple topical treatments especially. Now comes the part where we're not going to talk too much about it. We could spend hours just talking about this. It's extremely interesting. If you have a chance, just read up on some of the things that have been done and can be done for vitiligo when it comes to surgery. But we're talking cultured graft, cryogenesis, cryo treatment as well. When you have, especially when you have smaller lesions and when smaller and few lesions of vitiligo, causing a cryo blister could just, the healing process can trigger the melanocytes to come in. This also is injury, right? Punch injuries or needle injuries that could potentially get the melanocytes to reactivate in this area. Tattooing also is an option, of course. But the one thing that all of these treatments have in common, that you really should select for patients who have stable vitiligo. We should not consider surgical treatment for patients who do not have stable vitiligo. We also should not, or should be very cautious about doing surgical treatment in anybody who is still kebnerizing, has vitiligo that still kebnerizes, because you may cause more vitiligo at the end of the day. When you look at all these treatments, and I'm sorry, this slide I don't think is showing very well, but we're talking about surgical techniques that are really impressive and really interesting, right? From tissue graft to cellular graft, you know, from perifollicular graft, because you want to take the melanocytes around the hair follicles, and also non-surgical grafting technique like excisions, you know, micropigmentation or tattooing, causing wounds, so you can potentially reactivate or the melanocytes, or help melanocytes to be recruited to the area. So the surgical options for vitiligo have been are vast and have been being used for a long time. But that tells you the extent of that patients are willing to go to get their vitiligo better, and tells you the effect that it has on them. We'll talk about that in a bit. Last, if you can't get repigmentation, then let's get depigmentation. Let's get rid of whatever pigment is left. 20% monobenzyl ether of hydroquinone is approved, actually FDA approved, for depigmentation in vitiligo, but you can use another monomethyl ether of hydroquinone. Phenols can be used, laser combination therapy can be used, cryotherapy, and a plethora of herbal remedies can also be used. It can be impressive, you know, this picture and the before and after, and you can see just from Bindi here, and what you have, that this is a Southeast Asian patient. So it is being done, and for somebody to be willing to put up with this to get the vitiligo better, again, that is a hint of, if we don't know it already, how much vitiligo affects our patients and the psychosocial effects of vitiligo on our patients. And this is an article that was published 2021 in the HACD. Khaled Azzedine is in Paris, really does a lot of work on vitiligo, a really good guy, and has published tremendously on it. But this was a really good review, systematic review of vitiligo in multiple studies across the world that showed the amount of psychosocial effect that it has on these patients: depressive disorders, anxiety related disorders, stigmatization, which, by the way, is all over the world. It can be in the United States as well, and as well as other areas. Adjustment disorders, including sexual dysfunction as well, sleep disturbance. These are the things that came up often in these studies. And when they looked at the reviews, they looked at multiple articles. Again, the United States had about 16. India had more, about 20. But you can see that, again, Southeast Asia and Asia has quite a few articles on there, because vitiligo is a big deal over there. And looking at these articles, they were able to compare the psychosocial comorbidity burden in the patients with vitiligo compared to other skin diseases like acne, alopecia areata, atopic dermatitis, psoriasis, urticaria, and eczema. And often the burden of vitiligo was higher than the other dermatologic disease that we saw. So depression was more common in vitiligo than in acne, and some studies showed more common in vitiligo than alopecia areata, than atopic dermatitis, and psoriasis, urticaria, and eczema. Remember, we all hear a lot, and know, which rightfully so, know a lot about how much these diseases affect our patients, but we need to be aware of how much vitiligo affects our patients as well. And especially now that if we understand the tools that can help them, we should really be helping them. And we're talking about depression, anxiety, suicidal ideation, and suicidal attempts have been also shown in some studies, where vitiligo actually is above acne, above atopic dermatitis, and above urticaria as well. So sexual dysfunction is also part of it, and that is something that I do discuss with my patients. You know, having vitiligo in the genital area does affect patients tremendously. So, you know, in summary, this is, and we'll look at the polling questions again, but in summary, it's a disease state that affects our patients tremendously, that has other comorbidities. This is not just a skin disease, it's an autoimmune disease that, depending on when it shows up and why it's there, we should prompt us to investigate further diseases and further comorbidities, and we should really help these patients, you know, the best we can. All right, so let's go back to quick poll questions. They're the same questions, and I'm going to read them again and see if anybody was listening. So on histologic evaluation of vitiligo lesions, we can find melanocytes but not melanosomes, melanosomes but not melanocytes, melanosomes and melanocytes, neither melanocytes nor melanosomes. Please go ahead and vote. Look at that. So 65% got the right answer, neither melanocytes nor melanosomes. Again, melanocytes are destroyed, they're attacked in vitiligo, therefore do not produce melanosomes even within the keratinocytes. So when you do Melané or when you do Fontana-Masson stains, these will be negative. And let's do polling question number 3 again. Number 4. Which drug is FDA approved for the repigmentation of vitiligo? Number 1, tofacitinib, which is a Janus kinase inhibitor. Tacrolimus, which is calcineurin inhibitor. Ruxolitinib, a Janus kinase inhibitor as well. A and C, or all the above. Ruxolitinib at 56% is the correct answer. So tofacitinib is being studied but not approved yet. Tacrolimus is actually not approved, it's off-label as well. It looks like the most common, I guess, red herring or distractor was tofacitinib because it also is a Janus kinase inhibitor, being studied but not approved at this point. Okay. All right. So this ends the presentation. Thank you so much for having me. And please remember to all this when we're seeing these patients with vitiligo. I think one of the things we have done in our office is actually call back these vitiligo patients who sometimes don't come back very often because there's really nothing new when something new came last year. So we call them back and they're quite happy with some of the results they've gotten. If you have any questions, please submit them on the panel and we can, Dr. Issa will read them. And any other questions can be submitted at info@idefeducationalseries.com.
Again, remember the CME certificate will be sent to you and you must claim them by April 7th. Once again, thank you to our supporter, Insight Dermatology, for making this educational event possible. And we also would like to let you know that Dr. Pearl Grimes is going to be joining us on April 18th to also discuss vitiligo patient journey. So, Dr. Issa.
Fantastic, Dr. Hougeir. What an excellent talk. Thank you so much for enlightening our audience regarding this very debilitating disease. And so as a reminder for all those who are watching and tuning in, you can go ahead and write questions over on the bar on the right side, and then we can go ahead and go through them. And we have a question here from one viewer. It says, if you could, Dr. Hougeir, please give an example of a vitamin D analog that you use for treating vitiligo.
Calcipotriene.
Right, wonderful, and I do as well. Calcipotriene is a very well-known vitamin D analog used topically and is pretty much a mainstay in our practice. I have one for you, Dr. Hougeir, while our audience will input some more here. So there's different areas on the body that are more difficult to treat than others. For vitiligo, sometimes they say that the hands and feet, the acral areas. In your experience, do you think that using the topical JAK inhibitors such as ruxolitinib, do you get any good progress on those tough to treat areas?
So you could see from even the studies that the face the response is better on the face, but there is response in the body as well, especially hands. We don't have any other things we could do right from a topical standpoint. So we do use it on the body, we do use it on the hands. It is approved for that, but face usually improves faster than the rest of the body.
Wonderful. Another question from our audience here is, are there any contraindications for using ruxolitinib?
It is a Janus kinase inhibitor, so it has a black box warning like all the Janus kinase inhibitors that were there. Now it is a topical, so it's a class effect. So listen, at the end of the day, from a medical legal standpoint, if somebody just had a PE, I probably wouldn't put them on this. If somebody's pregnant, that would not be somebody I would select for that. If somebody is nursing, I wouldn't put on ruxolitinib either. I am, I'm comfortable with the topical Janus kinase, and we have to, in clinical setting, we have to be able to differentiate and talk to our patients. One, from the class effect and the ISIs, the important safety information that are there that the patients will read. So we need to be able to explain these to them. But then also, two, on the other hand, what is really happening with the drug itself, which is with the class effect itself. And remember, the class effect came from etoposide studies in combination with, in comparison with TNF-alpha inhibitors in rheumatoid arthritis patients who are over 50 years old, not a topical. So I still, if there is something that is obviously a big red flag, like somebody just got, had a blood clot, probably not my patient. Is it a contraindication? Yeah, potentially. And again, pregnant and nursing women probably would not be something I would use on.
Wonderful. And just to piggyback on that, actually, would be, I would agree with you, Dr. Hougeir, but also for those who are interested, looking at the pharmacokinetic studies that are typically done at the beginning of the clinical trial investigations, and you'll see specifically for ruxolitinib that, the systemic absorption is quite low. So for those who would like to feel, reassured in using these type of medications, would be to review those articles and make your judgment from there. But in our experience, the boxed warning is, fairly specific to or sister medications as well as the oral versions. Moving on to the next question, we said if a patient is doing well with topicals and has fully repigmented, do you counsel them to still apply topicals twice weekly to the previously affected sites for maintenance?
If they're fully repigmented, no, I do not. That's just my choice. Now I have colleagues who do that. And depending what we do with it, right? And it depends on the patient as well. If it has a history of getting better, and then the minute we stop, it gets worse again, then that's something I would consider. But if I get somebody fully repigmented, vitiligo comes and goes, and then it's not always the same site. So unless I have evidence that the same site comes back multiple times, I don't feel the need to do that.
Wonderful. The next question is, from a topical standpoint, do you use ruxolitinib on all areas up to 10% BSA, or just focus on areas that are most distressful to the patient?
Patients in the study were less than 10% BSA, right? And there's from a practical standpoint, there's only so much they're going to get in a tube. I think if somebody has, if we're concentrating, somebody has a much larger area than 10% BSA, I would concentrate on the areas that bother them the most.
Agreed. And which factors are affecting the percentage of response to treatment, such as age, possibly gender? Have you seen any epidemiological factors that affect the outcome?
I haven't. The longer and the more stable the vitiligo is, the less likely will respond rapidly to topical treatments. But we try. There's nothing to lose in there. And remember, these guys in the study were about many years of vitiligo beforehand. But remember, we're not talking, we're talking about a certain area, right? So you can have vitiligo in multiple areas. You can have years of history of vitiligo, but it comes and goes in different areas. So areas that are stable, that haven't, in my clinical experience, that haven't done anything for years are harder to treat. Areas that are now progressing, that are happening, that are new. Again, remember, when it comes to adults with new onset vitiligo-like lesions, there are multiple, look for melanoma. But if it's a new area, the faster we treat, the better when it comes to that. So length of presence, I think, to me, correlates with difficulty of improvement. But a lot of these patients in the studies had that. And remember, we're looking at 6 months out, and they've tried other things. So no, I don't have really a timeline where I say, no more topicals. I think it's an easy treatment and it's a safe treatment. Therefore, I would put them on topicals if I can.
Great. Another question here. Treated melanoma. Would you use Opzelura in those cases?
I'm sorry, I didn't hear you.
What about patients with a history of treated melanoma? Would you use ruxolitinib in those patients?
Again, what depends what we're talking about, right? Would I use any immunomodulator right in the field of where the melanoma was? No, I wouldn't use steroids either. If somebody had a melanoma that was treated on the back and they have vitiligo that I know is not because another melanoma is happening somewhere else, I'd have no problem using ruxolitinib on it. Again, as Dr. Issa said, it would be good to look at the pharmacokinetics of the absorption as well of ruxolitinib itself.
Dr. Hougeir, could you also comment on stopping the treatment and the rates of recurrence or flares?
I don't have those on hand. I know we're looking at it's being looked at. Again, it's unlikely that you stop treatment that takes months to get better, and in this case, and it would disappear. The effect would disappear right away. That would be really unstable for vitiligo. Vitiligo as a whole is usually pretty stable when they get to us. So I can't comment about it. I don't have the data. But I do believe few of our colleagues are looking at it. Remember, this has been out not too long, so you'd have to get them better and then stop it. So it takes a while to get these results.
Another question is, if you're starting to focus on repigmentation after stabilizing the condition, would you stop using ruxolitinib or any topical treatment and focus on saying using like microneedling or any other type of let's say like grafting, or could you do them simultaneously, or do you have any comment on that?
I don't have any experience with that. I don't use any of the surgical methods for vitiligo myself, and very few of us do not use these in dermatology in the United States. I think grafting and the microneedling potentially when it comes to that as a roughing, but very few of us do. But all these treatments that we talked about, all these can be and should be used in combination. This is not a disease that you treat with one thing at a time only, especially if it's not working the way you want to. If you have other options, we can use them all.
Right. I agree with you. And I think it's always important to, for those in the community who are doing those, would be to make sure that the disease is stable first and foremost, just to avoid any Kepnerization. But always combination therapy seems to be very symbiotic, if you will. It would be very helpful. Next question here is, someone commented, so in vitiligo, they notice a normal TSH, but positive antibodies. Is that typically the case, Dr. Hougeir, or have you seen a mixture of types of?
It can be. So when you evaluate thyroid disease, you're looking at TSH, you're looking at T3, T4, free thyroids, you're looking at antibodies as well. You're looking at symptoms. So the evaluation itself is something to consider. So if you have antibodies with no clinical relevance, I don't go after antibodies. I don't react just to antibodies myself. But if you have an inkling, or if you have more evidence that something may be going on, then an endocrinology visit is not a waste of time. So if you have antithyroid antibodies or antibodies that are there that you can find, but you can't find anything else, at this point we're dermatologists, I move them to the endocrinologist and have them do a full evaluation of their thyroid.
Absolutely. For our pediatric patients with vitiligo, do you have any first-line recommendations for therapy?
Anybody 12 or above, ruxolitinib has become first line and it's approved. It's better than the steroids long term. Otherwise, I use a lot of TCIs. Tacrolimus, pimecrolimus is what were my go-to before ruxolitinib became available.
And last two comments here before we wrap up the session. It's almost 8 o'clock here to respect everybody's time. This question is, do you see any contact dermatitis to ruxolitinib cream? And then the follow-up question here is, does insurance usually cover this medication?
Insurance depends. It's such a variable depending on where you are and what insurance and who's being treated. I've been successful in getting it covered. I think the company who makes it also had a good, at some point had a good program. You have to fight for your patient when it comes to this. With vitiligo patients, I do take pictures sometimes. I do, and we fight for it if we need to. So that's from the coverage standpoint. And again, when it comes to a branded name, each territory is so different, and each area in the ocean is so different. And I would use the companies, representatives of the company, the company resources that they have, that any company has, by the way, not just this one. One, to try to see if there's other ways I can get these or any drug to my patients, and how to do it so that I can what has been successful with other clinicians to get it done. Documenting things correctly, documenting psychosocial effects on the patients, documenting the amount of vitiligo that's present, documenting the previous treatments is helpful. All that is helpful to get it approved. And the other question was, I'm sorry, I got on a tangent here. What was it, Dr. Issa?
It was, do you see contact dermatitis to ruxolitinib cream?
Yes, it can happen. I haven't seen very often, but anything you use topically can cause this.
Well, that's all the time that we have this evening. I'd like to thank Dr. Hougeir and Issa for a great presentation and discussion on a subject that's really encouraging for healthcare professionals and their vitiligo patients worldwide. And we'd like to thank you all for joining us this evening. Good night, everybody.
Thank you. Good night.
Thank you. Good night.